Hi, good afternoon. Hope you have a good meeting so far. Thank you for coming to the session. This is a recurring session. We've been doing this since, I believe, 2012 or something like that, so it's been a long time. There are two topics we're going to discuss today. One is ruptured AAA. Dr. Tirado and Jason Nomura are going to debate on ruptured AAA, use of ultrasound for ruptured AAA. The second topic is necrotizing fasciitis. Dan Theodoro and myself, we're going to talk about that topic. Essentially, we're going to discuss pros and cons of using point-of-care ultrasound for those two topics. So we'll have approximately 8 to 9 minutes for each one of us to go over those topics. I'm not good at this, but Dr. Tirado and Theodoro are very entertaining. They have less content to present. So when you don't have content to present, they actually make their presentations more entertaining. So that, I know that's the show we need to put on more than the content. So that's the reason we invite them, not for their expertise. So they do a great job, and we get picked up every year for that reason, not for content reasons. So with that, we're going to start with the first topic, which is necrotizing fasciitis. So let me see if I can open up. I'll start first. So let's get started. So my goal is to see if I can convince you. All of you showed up here to, I know you've been using ultrasound, but kind of make my argument for using point-of-care ultrasound to diagnose necrotizing fasciitis. So I have a few disclosures. None of these have anything to do with my presentation today. So we all know necrotizing fasciitis, the condition itself, is on the rise, right? So because more and more patients are taking immunosuppressants, so we've been seeing a lot in Tucson, necrotizing fasciitis. The problem with this is early diagnosis is often very ambiguous if it comes to necrotizing fasciitis. And unfortunately, it is associated with a high morbidity and mortality. If you look at the studies, it goes anywhere from 20 to 70%, but at least the median mortality rate is 32%, which is really high. And it's even worse in patients who have history of diabetes and immunosuppression. So it's really crucial to make that diagnosis early so you can change patient outcomes. So we all know the limitations of physical exam findings, whether it is all these signs and symptoms listed over here. They are not frequently seen in patients, a significant number of patients. And really, that's where it becomes a challenge to make that early diagnosis. And that's where the point-of-care ultrasound kicks in. So I see a lot of ultrasound enthusiasts. I know a lot of you. So I know you've been using the ultrasound for a long time. So we all know the findings, right? So if you look at a soft tissue ultrasound, there is the hyperechoic skin. Underneath this is your hypoechoic subcutaneous tissue with echogenic fat strands. Underneath is your echogenic fascial planes and hypoechoic muscle with echogenic striation. This is something we have seen every day. All of you have scanned and found the patients, right? But if it comes to, conversely, when you scan patients with necrotizing fasciitis, there is diffuse thickening of the adipose tissue, and the fascial planes are thickened, and they're distorted, and there's fluid accumulation in the subcutaneous tissues as well as in fascial planes. Oh, thank you, Chris.
Thank you, Chris. Thank you.
You know, the very little content I'm going to present, Chris is interrupting it with his theory. All right.
Does Apple Maps give an option for travel by yacht?
All right, let's get back to it. So necrotizing fasciitis. So we talked about the ultrasound findings, which, and if you look at the most of the literature, they're talking about 4 millimeter fluid collection in the fascial layers, and there's a lot of discussion about air in the subcutaneous tissue. And again, I have no doubt you have seen these findings, and you have scanned these patients in your ED. And again, this talk is not about showing a fascinating cases of necrotizing fasciitis using ultrasound. This is more about making the case for ultrasound use in patients who are suspected to have necrotizing fasciitis. So, and again, this is one thing I want to highlight. We do see several of these patients, especially in our location. When we see something like this, we call either surgeons or podiatrists. The concept we deal with the residents is, if you see an open wound, do not assume the gas, what you're seeing in the foot or in the tissue adjacent to that, is just peri-wound gas. How do you make the distinction between a peri-wound gas versus actually the gas from necrotizing fasciitis? One thing we have found is, if you actually can determine the depth of the wound, you can probe or whatever you want to do. If the gas is surrounding at the deepest portions of the wound itself, then it is more likely going to be peri-wound gas. You don't have to think a whole lot about necrotizing fasciitis causing the gas. On the other hand, if the gas is away from the wound area, the deepest portion of the wound, it is more likely going to be necrotizing fasciitis. That's what our surgeons and podiatrists and all those people like it. So we scan, we try to probe the wound and see if it's away from the wound. Then we can say, hey, this is more likely necrotizing fasciitis. So I know this is all of you, when you scan, you are excited, you called your surgeons or whoever, and you made a difference. But we have Dr. Cochran from state of Missouri here, who always wants evidence, right? I've been working with this guy. I know this guy for more than almost 20 years. So 2 decades of, misery. So he always wants evidence, right? So this is where, let's see what evidence we have as of today for using point-of-care ultrasound in patients who are suspected to have necrotizing fasciitis. So let's start with something non-POCUS first. So here's a meta-analysis, 23 studies. Again, we talked about this. Not a lot of patients have these classic symptoms and signs. Again, same thing, even in this meta-analysis. They're showing the sensitivity and specificity the sensitivities are very low, so not so helpful. So how about x-rays? All our residents start with x-rays, right? So x-rays about 50% sensitivity, not so good. How about CAT scan, which is going to be Dan's favorite today? So you see gas, if you just look at the gas itself, it's about 88% sensitivity. But if you add other findings for fascial edema, fascial thickening, other findings to the gas, the sensitivity definitely goes up to 90s. And Lernex scores really got a lot of rep early on. Now we're starting to see there are significant limitations for Lernex scores. So again, if you go for a higher Lernex score, the sensitivity drops, and if it is like above 6 or equal to 6, then hovers around 70%. So if you look at other studies done for CT and MRI, diagnosing necrotizing fasciitis, again, depending on what they use their criteria. So in this case, the sensitivity is 86%, and specificity is about 76%. CT they only used sub-Q gas here, so it did drop to like 50% in this case. Another study here, looking at the MRI, they actually used a little bit of a different criteria in this study, and they used in conjunction with the Lernex scores, again, sensitivity and specificity is somewhat different. So what I'm trying to say here is, essentially, depending on what the criteria they have used, is it just sub-Q thickening, or is it fascial thickness, or is it fluid in there, or are they using more than 3 millimeters of fascial thickening, and involvement of more than 3 compartments, so the sensitivities and specificities are all over the place for CTs and MRIs. We understand there are better tests, but they are not perfect either. In fact, there are cases, I'm sure you have heard this too, where MRI was positive, taken to the operating room, there is no necrotizing fasciitis. And that's a problem with some of the very highly sensitive tests. So let's look at POCUS. This is the reason we are here today. So this is a prospective observation study done in patients who are suspected to have necrotizing fasciitis. An experienced operator performed this study. The protocol is nothing unique, scanning in 2 different planes. And they use the criteria of thickening of the subcutaneous tissues and a fluid layer of 4 millimeters in the fascial planes. And they compared it to the reference standard, which is PATH, essentially pathological findings in these patients. So they enrolled 62 patients, and 21 ended up having fasciotomy, and 17 patients had necrotizing fasciitis. And based on that, comparing with the reference standard, point-of-care ultrasound, the sensitivity and specificities are listed out there, which are not bad. So that's one of the studies from, I believe, 2010 or 2012, I can't remember, or it's listed here somewhere, 2002, oh yeah, okay. On the next study, if you have any questions, the man is right there. That's done in his shop. So essentially, it's also a prospective study. The difference here is the operators actually have varied ultrasound experience. Correct me if I'm wrong, Chris. And also, they use a little bit of different criteria. Not only they use the thickening of the subcutaneous tissues, but they also included the fluid layer and subcu gas as well. So those are the differences. And again, their reference standard was patients, they compared with the CT and surgical consultation. That's their reference standard. So they enrolled 64 patients, and they had 8 patients who had necrotizing fasciitis, and they did really well in this study. So I know Chris, when we were in the SURF meeting, he was telling me about this study. So I was really excited. We understand, like all of us understand, these are like small studies and small sample sizes and so on. But they really, POCUS has performed really well in these small studies. Just as an extension, we have an ongoing study in our shop. We already have a large sample. We're seeing similar sensitivities and specificities in our study so far. And we also noticed significant discrepancies between Larynx scores and POCUS findings and reference standards, in terms of fasciotomy. So we anticipate we're going to publish this data probably in the next few months. So I think the data is going to evolve. I think so far all the preliminary studies are showing that POCUS has value in diagnosing the necrotizing fasciitis early. Okay, and one other study I want to highlight is, this is a study they were looking at the thickness of the fluid layer itself in the fascia, and they looked about 5 millimeters, 1 millimeter, 2, 3, 4, and they found 2 millimeters actually has a better accuracy in patients. They enrolled about 95 patients, 2 equal groups, necrotizing fasciitis and non-necrotizing fasciitis, and they came up with this 2 millimeter cutoff. So I want to really highlight the concept which we really drill in our shop residency is time is fascia. You heard time is muscular, time is testicle, whatever. So time is fascia. So this is what I really wanted to make sure people understand. The reason being, there are studies out there showing if you forget about how long they had symptoms, once they present to the emergency department, if you actually intervene within 6 hours, the mortality is different from after 6 hours. And the similar data for 12 hours also in some other studies. So it really becomes important to actually make the diagnosis early on if it comes to necrotizing fasciitis. Let me give you some practical pointers besides the evidence we've discussed. So the patients who really need CT, you tell the nurse, I really need to get the IV quickly, and you go to trauma 1 hour later, difficult IV. Nobody cared, you're just waiting. So often, this happens often in patients who actually need CT right away. So this is I'm sure you have experienced similar problems in our shop. So that's one of the problems we have when you order a CT, waiting for that IV to be placed. As far as time to imaging, I don't know about your shops. I think it's the worst I've ever seen for the last 20 years probably in terms of transport, in terms of nursing. So this is not even anything to do with the COVID. So getting the patient to CT, it's going to take several hours. MRI, you can come back next shift. They're still waiting for MRI. I mean, I'm not exaggerating. Ask Josie and Garrett and others that are here from my shop. So that is not exaggeration. So we really, it is going to take forever to get some of these studies done. So what do we tell our residents? You go to the patient and see the patient. If you have suspicion for necrotizing fasciitis, you just scan. And then you see something suggesting some evidence there, you have to call surgery team. Don't worry about IV, don't worry about labs. If you meet any resistance, tell the attending has to call that other attending. Because we feel necrotizing fasciitis, every minute is valuable, and we have gone through the peer reviews where we didn't do this. So this is the preaching in our shop. You have to scan, you have to ultrasound patient as soon as you suspect. And besides all that, how not so exciting to check and review a CT. Isn't this better to diagnose in hi-fi and, in the ED? Isn't this the reason we did the fellowship? I mean, Dan, are you listening to this? No. All right. All right. So not exciting to order a CT. All right, and cost, right? Cost is high for all of this stuff, right? And if it comes to ultrasound, just like that isn't that true? MasterCard commercial, right? So it's priceless. So this is what I propose. because of the fact this is a deadly disease with a high mortality and limitations of physical exam and challenges sometimes to get the CT and so on, I think if you do that ultrasound first, you can make the diagnosis early on, probably, and you can call the surgical consultation early on. And even if you want to get the additional imaging, you are going to expedite that imaging and probably decrease the time to operate intervention, and maybe even change the mortality and morbidity in these cases. And I guarantee you the data is coming, whether it is sensitivity, specificity data, more robust data, and also time for all of this stuff. I'm going to stop there, and I'm going to pass this on to Dr. Theodora.